Dr. Naveen. Very good evening to respected seniors and dear friends. Today we are starting the first of the webinar series, and I welcome Dr. Yashveer Arya, who is a dynamic anesthesiologist as well as the Secretary, Haryana State. Please, Dr. Yashveer, say something.
Thank you, Dr. Nirupma, for your kind words. A very good evening to all my seniors and dear colleagues. It's my pleasure to welcome you on board for a series of webinar being hosted by Indian Society of Anesthesiologists, Haryana, with a rock-solid backing of Dr. Naveen Malhotra, and I must confess, Dr. Naveen Malhotra and Dr. Sethi. Without their efforts, it would not have been possible. I must congratulate Team ISA Faridabad to take the lead in this academic fest. Now, without wasting time, I welcome Dr. Ved Popley, Secretary ISA Faridabad, to take over the proceedings. Long live ISA.
Thank you, Dr. Yashveer. Hello.
Yes, sir.
You're audible.
Yeah, thank you, Dr. Yashveer, for the nice introduction. I just welcome to all this new webinar series hosted by Haryana State Branch. The first of which is just initiated by Faridabad branch. And I will welcome on board all the people, all the delegates, all the participants who are just logged in and are with us, and also all the dignitaries who just chosen to be a part and parcel of this, the very first webinar. The participant, and beside this thing, I just want to introduce today's presentee, who is Dr. Devesh. He's a well-known organizer and a speaker, and he's well-known in circle in the. He has been past president of the ISA Haryana, and currently he is with the Asian Hospital, a very prestigious institute in Faridabad, and associate director and HOD and OT services. He respected, and he commands a green OT assessment. He is in great demand as a green OT assessor. His area of interest is quality and safety in anesthesia, ultrasound guided regional anesthesia, fluid management strategies, intraoperative lung ventilation strategies, and overall a very helping colleagues to our branch and in total Haryana as well as at national levels. He will be presenting you a very pertinent topics. He has a deep interest in, of course, in the regional anesthesia also, but anesthetic management of PIH. And second speaker following him will be Dr. Rashmi Gurmani. She is a MD, VH University, postdoctoral fellowship in critical care medicine. She is reading now professor as associate professor in ESI Medical College, Faridabad. She has been a dynamic as ISA member and has been active in all the events hosted by the Faridabad branch during this COVID period, last 6 months. A good office bearer, and she is a prophetic speaker with deep academic interest. She will be also delivering a talk on very pertinent topics: peripartum cardiomyopathy, anesthetic considerations. Now I just request Dr. Devesh to take over and give a presentation. Thank you.
I request Dr. Sunil to say some words, because without his efforts, this webinar would not have been possible. Dr. Sunil, please.
Thank you very much, Dr. Nirupma. And it is like I'm in the middle of the stage, and my right hand is Naveen, left hand is Faridabad branch. Whenever I look forward, first of all, I look forward to Faridabad branch, and definitely Naveen is of the backbone of ISA Haryana. And whenever I see good speakers, good chairpersons, and my teachers, my vision goes to Rohtak, Faridabad, Gurgaon, and definitely to other cities also. But these are our main branches. And Dr. Nirupma, Dr. Ved Popley, President Faridabad branch, they are working very hard. I must appreciate. And whenever I asked Dr. Sangeeta Khanna, today I talked to Dr. Devesh also, he said, sir, after these 8 city branches, we will have another meeting, and the topic which you will give it to me, I will be honored. And this is his, rather I could say, he's a very good teacher also, and a very good person also, and academician. So not going beyond this, and we have to start the academic meeting, but we are lucky to have our chairpersons, Dr. Savita Saini. She is professor and head of the TJMS Rohtak, and my guide also. Then the another speaker, another chairperson is Dr. Suresh Singhal sir, and it's lovely to work with him. And Dr. Sangeeta Khanna is with us, and she is head of the department anesthesiology at Vedanta Hospital, Gurgaon. And Dr. Sudha Sood, she is head of the department at ESI. And notwithstanding in between the speakers and the audience, thank you very much.
Thank you, Dr. Sunil. I just invite Dr. Naveen now because he is the brain behind all these. So, Dr. Naveen, please say something, then we will be able to start the webinar.
Thank you, Dr. Nirupma, and welcome to all the members of Society of Anesthesiologists Haryana, the ISA Haryana webinar. And just slightly correct, it is the third one. So we had two webinar meetings in the past when the COVID was in the peak, and where the speakers were Dr. Sangeeta Girdhar and Dr. Nirupma themselves. So heartiest congratulations to Dr. Sethi, the presiding officer of today's webinar, and Dr. Yashvir Arya for hosting this webinar series. And heartiest congratulations to Dr. Copley and Dr. Nirupma Bansal, the president and secretary of the ISA Hyderabad City branch, for organizing this particular webinar. And no webinar is complete without the icing on the cake, the faculty. Dr. Devesh Arora, past president of ISA Haryana, my colleague at Rohtak, ex-colleague at Rohtak, and now at ESI Hyderabad, Dr. Rashmi Virmani, and very esteemed chairpersons, patron ISA Haryana and president ISA Rohtak City branch, Dr. Savita Saini madam, Dr. S.K. Singhal, past treasurer ISA Haryana and senior professor at Department of Anesthesiology at VJMS Rohtak, Dr. Sangeeta Khanna, past president ISA Haryana, and Dr. Sudha Sood, senior professor and head anesthesiology at ESAIC Medical College at Hyderabad. See, I have been attending webinars across the country to the extent of at least 3 to 4 per week. So I'm now very happy that we shall be attending our weekly webinars, which are being planned by Dr. Sethi and the team at different branches of ISA Haryana. As of now, we have got 8 branches: Faridabad, Rohtak, Gurgaon, Karnal, Hisar, Bhiwani Jeend combined, and Sonipat, Panipat combined, and Molana. But I must say, Dr. Yashvir and Dr. Sunil Sethi, we should start working on having new branches like Ambala, Agroha, Yamunanagar, and Panchkula. In addition, Bhiwani, Sonipat and Panipat can now be independent branches with the number of anesthesiologists going up in the 2 cities. And I must also compliment ISA Haryana, which has been implementing the ISA national programs immediately. Yes, it's my home state. I'm really proud of that. Whether it was grant in aid, personal efforts were taken by Dr. Yashvir and Dr. Sunil Sethi for arranging the PPEs and ensuring its distribution. And in addition to the national grant, they spent a lot of money from the kitty of ISA Haryana also to ensure in the March-April time the PPEs were given to all the anesthesiologists. The ISA appreciation certificates, ISA online mechanical ventilation module was inaugurated, and the first course was held by in the state of Haryana itself with Dr. Sangeeta Khanna, Dr. D.K. Srivastava, Dr. Nirupma Bansal, Dr. Sunil Sethi, and Dr. Yashvir Arya were the faculty. And the online practical course was conducted by Dr. Sunil Sethi and my young colleague at Rohtak, Dr. Monica Chikara at Yamunanagar. And then very active participation by ISA Haryana in World Anesthesia Day celebrations. And in the Yuva ISACON, the Society of Anesthesiologists Haryana was the organizing branch which hosted organized the Yuva ISACON, which was hosted by ISA National. And there are very active participation by the anesthesiologists of Haryana in the IJA Northern Supplement with Dr. Jatin Lal as associate editor and Dr. Tina Agarwal as an assistant editor. and with very excellent reviewers by Dr. Kiran Preet, Dr. Mamta Bhardwaj, Dr. Renu, Dr. Mamta Jain, Dr. Priyanka Bansal, and Dr. Kiran Preet. And Yuva ISOCON coordinators were also a lot of active participation from the state of Haryana, being the organizing committee, Dr. Monica Chikara, Dr. Kamna Kakkad, and Dr. Kul Saurabh Kaushik. And in the World Anesthesia Day, we had a comparer from Rohtak only, and she became a national comparer, Dr. Preeti Gehlot, by doing an excellent, being an excellent master of ceremony, where the international guests were invited. In the ISA Fit Anesthesiologist campaign, Dr. Vineet and Dr. Garima Vaid, both of Rohtak, and Dr. Ritu Jasuja Chopra of Hisar, they are national icons by their activities in the to keep themselves fit. And for the Environmental Day celebrations, we had winners from Haryana in slogan writing. Dr. Kamna Kakkad was the first prize winner, and she is also the winner of the free bursary of WSA. Free registration she got for the European Conference of Neuroanesthesiologists, which was held on the last weekend of the November. And I must also place on record the efforts of Dr. Prabhakar Sharma, past president of ISA, and he is currently serving his term as president of IMA Haryana for doing a lot of good works under the banner of IMA. As far as ISA National is concerned, we have been active in the COVID pandemic, but with New Year's, new horizons are coming up. We are launching in the new year ISA National Registry, which will be a biggest event in the form of there will be data recording across the country. That will be absolutely safe and secure and confidential. But we will come to know how many laparotomies were done in a particular day in India, how many cesarean sections were done, how many neurotrauma cases were done. And it is a big exercise which the ISA National Headquarters is working. And we are also launching our ISA app. In the new year, uniform PG curriculum and UG curriculum in anesthesia that will be launched across the country. And in addition to, we are starting with multi-centric trial under the banner of ISA with funding from ISA. Also, we are funding the ISA state conferences because we can have physical meetings. So ISA sponsored CMEs, that fund is being given to the state conferences for doing a virtual conference so that academic activities are continued under the banner of ISA. And then we will have our ISA MidCon 2021 in the form of UI ISACon 2021, which is my favorite area of interest because I am looking personally after that department. Also, we are starting with ISA skill centers. First, we will be having virtual one and then a physical one. But all these have been possible because of the team effort, whether it is the different ISA city branches of the state of Haryana, different ISA state branches across the country, along with the ISA national. So I am very sure that we will have a very active participation in these webinars, and the show will go on and we will meet every weekend, Sunday 5 to 6:15 p.m. And next is definitely my home city branch. ISA Rohtak city branch will be doing it, and Dr. Savita Saini, madam, will be deliberating about it more at the end of today's ceremony. Thank you very much. Long live ISA. Jai Hind.
Thank you, Naveen. Now I'll request Dr. Divesh to start his presentation, and all the chairpersons are there. I request them to please be there in support. Thank you very much. Dr. Divesh, please.
Is my screen visible to everyone?
Yeah.
Okay. Respected seniors, friends, and dear colleagues, a very good evening to all of you. At the outset, I bring greetings from Asian Institute of Medical Sciences, the place which I've been working for the past 10 years or so in various capacities and currently as the head of the department.
Divesh, you can make it full screen by pressing the...
Just a minute, I think there is some technical glitch. I'll start sharing my screen again.
Yeah, it's fine.
Okay. So The learning objectives for today's lecture are going to be basically under the obstetric terminologies and practices, the blood pressure control, the seizure prophylaxis and control, the anesthetic management, fluid management, and in the end, we would like to take as many questions and answers as it's possible for us. So first and foremost is how do we classify hypertensive disorders of pregnancy? This classification has been made possible by American College of Obstetricians and Gynecologists. They conducted an exercise and they published the executive summary in 2013, and these were called as the guidelines. So they have classified hypertensive disorder pregnancy in 4 categories. The first being chronic hypertension, which is present in a pregnant woman prior to 20 weeks, which can have a preeclampsia superimposed on it. Next is gestational hypertension, which means hypertension detected after 20 weeks without proteinuria, and the classical one being the preeclampsia-eclampsia syndrome, which we are going to discuss in detail. So how is it defined? Is it defined by a systolic blood pressure more than 140 and a diastolic of 90 millimeters or more, at least 4 hours apart with 20 weeks of gestation? And proteinuria. So proteinuria is 300 milligram per 24-hour urine collection, or protein creatinine ratio greater than or equal to 0.3, or a dipstick reading of 1+. Previously, proteinuria was mandatory. From 2013 onwards, proteinuria is not mandatory. So a new onset hypertension with any of these followings, like thrombocytopenia less than 1 lakh, creatinine more than 1.1, impaired liver function test, pulmonary edema, cerebral or visual symptoms also gets classified as preeclampsia.
Dr.
The
Divesh, your
terminology.
slides are
We
not
cannot
coming.
see the slides, Dr. Divesh.
1 second. Now my slides are visible.
No, no.
You are visible, sir.
Are the slides visible right now?
No, no.
You are visible.
Slides are not
Let me-
visible.
Okay. Right now they're visible to you?
No, sir, no.
No.
Not yet.
Is it visible right now?
No, Devesh. Devesh, can you mail it to me? I'll project it for you, if you don't mind.
Let me try once and I'll mail it to you, sir. Because on my screen it is showing.
You can share the screen.
Sir, is it visible right now? Are my slides visible, sir?
No, Devesh.
From my end, it's clear. I think I would request Dr. Rashmi to take over the presentation from, and in the end, I can present my presentation. And in the meanwhile, I'll mail my presentation to you, sir. I think we should not be wasting time.
So can I start, sir, or shall I wait?
Rashmi, I think your things are visible. So you just please, with the permission of chairpersons, definitely let the chairpersons make a call.
Yes, yes, I think we can do that. I'm okay, ma'am, Dr. Savita.
Yeah, we can start with Dr. Rashmi's presentation right now.
Yeah, we can start with Dr. Rashmi's presentation, I think.
I think Dr. Devesh's screen has started sharing now.
Started sharing.
There is some confusion actually, whatever. So let's see if he's able to do it within 2 minutes, it is fine. Or else we move over to Dr. Rashmi then. Is that okay?
Yes.
Okay, ma'am.
Okay.
Now my screen is visible.
Yes.
No, it's not
It is
visible.
about
It's
to come.
blank actually. Yeah.
Actually, Devesh, your net speed is less.
Hmm.
That's a time lag. The way you're speaking and the thing is coming. I'll help you out. Let you stop sharing it and let Rashmi start it, and then we can. Otherwise, it will be very slow.
Okay, sir.
Rashmi, please go ahead.
Okay, sir.
But Dr. Devesh's screen has not stopped.
Yeah, that's what. Stop.
Unless that is stopped, you can't probably show yours.
Is it visible?
Yeah.
Yeah, now it's
Yeah.
Yeah.
Rashmi, you can make it full screen.
Okay, ma'am. Okay.
All the best.
Okay, thank you, ma'am. A very good evening to chairpersons, my respected seniors and my dear friends. So we will start with this presentation at present. It is about anesthetic management of peripartum cardiomyopathy. And I'm Dr. Rashmi, working as Associate Professor in Department of Anesthesia at ESIC Medical College. So we'll be taking the topic under following headings. Am I audible to everyone?
Yeah.
Yes.
Yeah, thank you, sir. So we'll be taking the topic under following headings. Why should we know about peripartum cardiomyopathy? Is it important to know about it? What is peripartum cardiomyopathy? We'll touch upon the pathophysiology of peripartum cardiomyopathy, and then we will discuss the anesthetic considerations if a patient of peripartum cardiomyopathy presents to us for vaginal delivery, cesarean section, or in acute decompensated stage in ICU, and then take-home messages will be discussed. So is it a problem? Is peripartum cardiomyopathy a big problem for us? I would say yes, although it is supposed to be a rare disease, but Michael C. Honigberg and Michael M. Gewertz in their review in British Medical Journal in 2019 have shown that incidence of peripartum cardiomyopathy in Nigeria is as common as 1 in 100. And in Japan, it is as rare as 1 in 20,000. So it is definitely a concern. It's as common as 1 in 100 in Nigeria. But what about India? In India, precise incidence is not known, but Pandit et al. From Kasturba Medical Colleges have shown in one study that incidence is as common as 1 in 1,374 births, but yet precise incidence from all over India is not yet known. This is one of the reasons. So you can see it's not that rare. And we must know about it. It's a significant cause of maternal morbidity and mortality. Mortality can be as high as 50%. You can see here. And if there's a delay in diagnosis, which can actually happen because presentation of peripartum cardiomyopathy resembles signs and symptoms of late pregnancy or early postpartum period. So it is very likely that it may get missed. Diagnosis may get delayed or it may get missed. So to the patient, we actually can't say that we are sorry for the delay. It will cost patient his life, her life. So that's how, these are the reasons why we should know. It is not that rare, one thing. Second thing is diagnosis can be delayed. And thirdly, morbidity and mortality is very high if it is not diagnosed timely. Now, what is peripartum cardiomyopathy? Recently in 2010, Heart Failure Association of European Society of Cardiology gave a revised definition. I have highlighted the important points. You can see it here. It's an idiopathic cardiomyopathy presenting with heart failure secondary to LV systolic dysfunction. It's important, it's LV systolic dysfunction. and it presents more towards the end of pregnancy or in the months following delivery. An important thing is no other cardiac cause was found in such cases. So it's a diagnosis of exclusion. And looking at the echo findings on echocardiography, LV ejection fraction is less than 45%, and there may or may not be any ventricular dilatation. So that's a revised definition. Earlier, the definition was that cardiomyopathy is diagnosed from the last month to 5 months postpartum, but now it has been revised from the end of the pregnancy to the months following delivery. So that's a change from the previous definition. Now, which all patients are actually predisposed to develop peripartum cardiomyopathy? So you can see it is more common in African American women. The incidence is as high as 16 times more common in preeclampsia. 22% of preeclamptic women have shown to have peripartum cardiomyopathy. More common in, again, diabetics. Older maternal age and teenage pregnant patients are more likely to have it. Obese parturients and those who are smoking are more likely to develop peripartum cardiomyopathy. Now, I'll just touch upon pathophysiology. See, exact mechanism why PPCM develops is not known to anyone, but they have proposed a multifactorial etiology. And what is suggested is from pituitary, prolactin is released during pregnancy, you can see here, and there's excessive oxidative stress in pregnancy because of increased level of low density lipoproteins. Because of that, this prolactin is converted to 16 kDa prolactin fragment, which actually causes cardiac myocyte apoptosis through endothelial dysfunction. On the other hand, from placenta, in patients who are predisposed to peripartum cardiomyopathy, they tend to have more of soluble FM-like tyrosine kinase, increased levels of tyrosine kinase, soluble fragment, and then that again causes endothelial dysfunction and cardiomyocyte death. So these two mechanisms are two-hit hypothesis. Along with that, people say some patients who are genetically predisposed are more get affected by prolactin fragment and with increased tyrosine kinase levels. So it's a combination of pregnancy-related factors, hemodynamic stress of pregnancy, high prolactin levels, and genetic predisposition, which finally leads to peripartum cardiomyopathy. Exact mechanism is still not known. These are various hypotheses. And besides, initially there was viral etiology which was proposed. And people say that there are autoimmune antibodies which work against your cardiac muscle, and that also precipitate cardiomyopathy. So that's just about the pathophysiology. So till now we have discussed why we should know about peripartum cardiomyopathy, what is peripartum cardiomyopathy, and just touched upon the pathophysiology. So what about us? How is it relevant to us? So for us, either a peripartum patient with PPCM presents to us for labor analgesia, or for cesarean delivery, or for in an acute decompensated stage in intensive care unit. So generally for these reasons, patient present to us as an anesthetist. So if the patient comes to us for pre-anesthetic evaluation, these patients, we should have a high degree of suspicion while assessing obstetric patients, although that's not always possible considering the emergency. But family history should be taken in detail because there's some genetic predisposition proposed. Some patients have past obstetric history, past history of abortions, repeated abortion, or cardiac illness in the past. And we should ask in detail about the treatment history, whether they are on any nitrates, diuretics, beta blockers. If they are diagnosed in antepartum period, they have to be started on anti-cardiac failure measures. We should look at the associated risk factors, which we discussed earlier, like smoking, multiparity, preeclampsia. So that all factors we should keep in mind. If patients have all those factors, we should be more suspicious and we should take a detailed history regarding previous cardiac illness. Although even with the detailed history, we might not be able to suspect or diagnose peripartum cardiomyopathy. Because see, it has happened with us also once that the patient was completely asymptomatic and they presented with asymptomatic, no symptoms. We took, it was a category 1 LSCS. We took up the patient. We had to give GA due to other reasons, but patient developed perioperative hypotension. Some ectopics were there. These were the only positive findings. And while post-op evaluation was done because of for hypotension, patient was found to have a EF of around 35 to 40% and was started on anti-failure medications. And she recovered, but that doesn't happen always. So a high degree of suspicion again is very, very important because normal changes in the pregnancy when it is full term, patients can have near-term dyspnea, some degree of orthopnea can be there, they can have fetal edema, they can have fatigue, easy fatigability, so it's difficult to distinguish. Less commonly, patients present in shock, and especially ejection fraction is very low, or arrhythmias, or they have history of thromboembolic episodes if the ejection fraction is very, very low. So must say that high degree of suspicion has to be there. Now, there's no shortcut to success. So, but here, even if we take a detailed history, we are likely to miss peripartal cardiomyopathy. Sometimes we can miss. So after a detailed history taking, physical examination, there can be, everybody knows there can be pulmonary crepitations, raised JVP or S3 gallop. ECG may show non-specific STT changes, or QRS duration can be more than 0.12 seconds. And that has been shown to correlate with mortality of PPCM. Chest X-ray, if it is available, may show features of pulmonary edema, cardiomegaly, or pleural effusions. Anti-proBNP levels can be raised. It can be more than 128 or very high also. And troponin levels are also raised at times. But anti-proBNP rise is not very specific. It can rise as it can rise in many other cardiac conditions. And one more important thing I would like to say here is, in peripartum cardiomyopathy, symptoms onset is mostly in the late pregnancy, that is in the around the 3rd trimester. However, if patients have other cardiac illness, they generally present around 2nd trimester because that is the time when cardiac output and stroke volume rises maximum. So most of the patients who have another causes of cardiac disease generally present around 2nd trimester, like valvular heart disease or other cardiac illnesses. But peripartum cardiomyopathy generally tends to present towards the late trimester, and as high as 60% of the patients can present in the postpartum period, in the first 1 month after delivery. Now, echo is diagnostic. There is LV ejection fraction, which is less than 45%. There may or may not be LV dilatation. There can be functional MR and TR and biatrial enlargement. There can be evidence of thrombus also if ejection fraction is very low. Other than that, routine investigation needs to be done. So these are the findings on echo. You can see evidence of mitral regurgitation here. LV is dilated in this case. Now, if a patient in postpartum or late antepartum period presents with dyspnea, there can be numerous differential diagnoses. I hope everyone agrees with that. Like if patient has pulmonary edema secondary to preeclampsia, it might be very difficult to distinguish. If patient develops amniotic fluid embolism in immediate post-op period, postpartum period, that also can be, it can be difficult to diagnose. So if the presentation of the patient is before the 36th week of pregnancy, as we already discussed, there can be pre-existing dilated cardiomyopathy, pulmonary edema secondary to preeclampsia, etc. If presentation is after 6 months of delivery, again, there can be underlying dilated cardiomyopathy or myocarditis. If presentation is after complicated or traumatic delivery, you must think of amniotic fluid embolism or Takotsubo cardiomyopathy. And if presentation is acute and immediately after mesoprostol administration, we must consider coronary artery spasm or amniotic fluid embolism again. And if the patient is presenting with prime presentation is history of palpitation and there are tachyarrhythmias, you must rule out arrhythmogenic right ventricular cardiomyopathy. Now, so that is about the pre-op evaluation, right? So once we can take a physician and cardiologist opinion, get an echo done, patient can be started on anti-heart failure measures so that condition can be optimized. Like they can be started on nitrates, beta blockers, digoxin. ACE inhibitors are contraindicated in pregnancy and should not be used. Other than that, patient can be started on digoxin, and if ejection fraction is very, very low, they can also be started on low molecular weight heparin by the cardiologist. Now, coming to the mean anesthetic management, it's a multidisciplinary approach. So it is a team approach which we have to give to the patient. Like neonatologist is involved, your gynecologist, cardiologist, intensivist, and anesthesiologist all have to put in their role for management of this patient. And if we want an anesthetist, if the gynecologist team want labor analgesia or help during cesarean delivery, then a case should be reviewed by anesthesiologist in the timely manner. And in antepartum also, if patient is, generally patients are well compensated, so pregnancy can be continued. And whether the patient will go for a normal delivery or cesarean delivery, that is generally due to obstetric reasons or based on the patient wish. So whatever management we do, whatever anesthesia or whatever type of anesthesia we use, there are certain goals which have to be kept in mind. Like we should maintain our myocardial perfusion by avoiding arrhythmias, episodes of hypotension has to be avoided. We need to maintain our preload and prevent increased afterload. So this is very, very important. So before we go further, one thing I would like to say here is, if a patient presents to us in emergency, what do we do? It's very difficult to suspect at that point of time that the patient has peripartal cardiomyopathy. There's no time basically. So it is better that we get an echocardiography can be done at the time of last ultrasound of the patient. When the patient goes for their antenatal checkup and when the last trimester ultrasound is done, at the same time, echocardiography can also be planned. So that will help us to diagnose a condition which is generally missed by the history. One is that. Second option is, second other thing I would like to discuss here is, we all are using ultrasound for the job procedures, right? So here what we can do is we can also have an echo probe and just do a screening echo to see that ejection fraction is all right, even if the patient is coming to us in emergency. So that is one thing which can help us in not missing the diagnosis of PPCM. One is doing screening echo at our center only if facility is available. And if facility is not available, then that can be done when we are getting our third trimester ultrasound done. So a screening echo can help us in avoidance of missing of the peripartum cardiomyopathy diagnosis, because it is associated with very high morbidity and mortality. And it is very important that we reduce that. So coming back to anesthetic management for vaginal delivery. Now, see, as an anesthetist, we can be called for management of labor analgesia because pain, anxiety, and increased sympathetic nervous system activity can lead to increase in afterload, and uteroplacental perfusion can be decreased. So labor analgesia has to be started as early as possible for such patients, and regional anesthesia is the anesthesia of choice preferably. And it should be instituted with adequate hemodynamic monitoring. And also we have to avoid aortocular compression. So regional anesthesia is the preferred option because sympathectomy, which is there with regional anesthesia, this causes a decrease in preload, afterload, and catecholamine levels. And second stage of delivery needs to be shortened. Again, for cesarean delivery, choice of anesthesia technique depends upon how urgent is the delivery. One is that, and how is the physiological condition of the patient. What is the optimal anesthetic technique is very controversial, but whatever technique we decide, we should keep the basic goals of management in our mind, which we discussed earlier. Like there should not be sudden decrease in preload and afterload, and there should not be too much of myocardial depression. Cardiac contractility has to be maintained. Preload needs to be reduced, but not very fast, so that perfusion can be maintained. GA is generally for anticoagulated patients who are presenting to us for cesarean delivery, and there's no time to stop anticoagulation. And for emergency cesarean sections, category 1 CS, and for decompensated patient, it's better to institute invasive monitoring in time, and then the same goals have to be kept in mind. Although rapid sequence induction can be challenging with compromised cardiac function, and opioid-based induction, if you are using for stability, there can be chance of post-operative ventilation might be required, and pressure response to intubation need to be attenuated. So, as I said, whatever the technique, we have to keep the basic goals in mind. We can use titrated neuroaxial anesthesia, like continuous epidural anesthesia, combined spinal epidural. Continuous spinal anesthesia has been used by many people, and volume expansion epidural also has been used, and regional has its own advantages, and we all know about it very well. Although unpredictable fall in preload and leading to decrease in cardiac output should be avoided. Then a word of caution about uterotonic drugs. Oxytocin has to be used very slowly, as it can cause sudden decrease in systemic vascular resistance, and ergometrin should preferably be avoided for such patients. So there was a review by Rashmi Ramachandran regarding anesthetic management of patients with peripartum cardiomyopathy, and they have shown that GE, epidural, CSC, spinal, and others have been used, which includes epidural volume expansion, with different outcomes depending upon the condition of the patient. So once the patient is in ICU with you, what should be done? Just a word I would like to say here. I would like to focus here. If the patient is in severe acute heart failure or cardiogenic shock, we need to optimize preload, optimize oxygenation, add inotropes, urgent delivery, and consider bromocriptine in postpartum period. See, because it is reversible, we should consider mechanical circulatory support if required for patients. So bromocriptine is now being considered for peripartum cardiomyopathy, and we need to give anticoagulation with heparin if we are using bromocriptine. This is the therapy which is recommended for cardiac failure. Bromocriptine, this is both bromocriptine, oral anticoagulants, oral heart failure therapy, vasorelaxing therapy, and diuretics. Mind it, post-operatively, you need monitoring in ICU. So we should take up this patient where we have post-op intensive care facility and availability of cardiologists around. It will be better to take up in such a setup. And we need to consider careful fluid management in post-op period, and as well adequate analgesia needs to be done, and bromocriptine and ACE inhibitors can be added. Patients who have ejection fraction less than 30% and marked LV dilatation and RV involvement, they have worse outcomes. And patients, if have subsequent pregnancy, are likely to decompensate in those pregnancies also. So I would like to conclude with following words, that this disease has high morbidity and mortality. It is difficult to diagnose as symptoms are very similar to normal pregnancy. Consider echo, as echo can be considered if you have any doubt. Multidisciplinary approach is required. Careful selection of drugs and slow and judicious titration, rather than what technique we are using. Although spinal should be avoided, rather than what technique we are using, it's the goals we have to keep in mind. That's what I would like to say. Thank you so much for the hearing. Thank you.
Thank you, Dr. Rashmi, for the excellent talk. Dr. Sethi, do we have to take the question and answer right at this time or at the end of the both the presentation?
You are the chairperson, you can decide.
No, if any criteria has been set, so we can do that way. Or else I would like...
We can have 2 questions, 2 to 3 questions.
Okay. So...
Madam, your video is off.
My video is off. Okay, let it be. I'll just do it. Yeah. Now I'm visible?
Yes, ma'am.
Yes, ma'am.
screen is having some list kind of a thing. I don't know
Devesh,
what.
your screen is still sharing, so stop it, please.
Okay. Anyway, doesn't matter. So, Dr. Rashmi, it was an excellent presentation. Looking at the presentation and the incidents which you have mentioned, it is not very uncommon also. And a good message has gone that one has to have a high index of suspicion for the presence of this very problem, which can carry a high degree of morbidity and mortality. To add upon this, I think you mentioned about a continuous spinal anesthesia. I think when nothing else works and probably facilities or something, if somebody is having, if during time one knows patient should be referred to higher centers, but
Right.
in emergency has arrived and nothing else, and probably that can be chosen. That is what my personal
Yes,
opinion also is. Probably literature also throws more, can throw more weight on it. Can you add upon few more sentences on that continuous spine? Dr. Rashmi,
Yes,
please.
ma'am. There is a presentation from Rohtak only. One case report is there by Sushila ma'am and Rajmala ma'am. They have given continuous spinal anesthesia for a patient in which they inserted epidural catheter only in the spinal space, and titrated low doses were given. And
Yes.
so that because it is titrated, your hemodynamic stability is maintained wonderfully and your level is extended to the desirable level without much hemodynamic compromise.
So that the message goes that that method can be safely utilized if situation demands so. So
Right.
probably, okay. Any other, any other question by someone?
I would like to add, madam.
Dr. Sethi?
Yes, madam. The only thing is we have to be more suspicious whenever we are working in periphery and the patient is going into hypotension post-operatively. I have received calls from 2-3 colleagues from periphery, and I too had one patient postpartum cardiomyopathy. Whenever the patient is going into hypotension or she is desaturating, we must ensure that the echo is done at the earliest, and we have to be very suspicious about this. Although it is very rare, and we land up in the problem if we defer the case.
Okay.
Ma'am, I have just one question. You were talking about oxytocin.
Right, sir.
Explain regarding these uterotonics,
Yes, sir.
whether
So
they can be used.
oxytocin can be used, sir, but in a very low doses and very slowly it has to be given. Now they say that 3 units are also effective. Even
Yeah.
less than that has been documented.
Because what we have been practicing is something more than 3 units.
Right.
Something more than 3 units, maybe 20 units, maybe 15 units. But recently I came upon a data which was suggesting some very low doses of oxytocin to be used. But our gynecologist colleagues are not so happy with these low doses, and they want push more.
Sir, I think we can start with the low dose of 3 unit, which can be given over a period of 1 minute. And then uterine contractility can be reassessed and further doses can be given accordingly. If the uterine contractility is poor, further boluses of 3 units, which has to be given again slowly, can be added upon.
Yeah, very true. I agree with Dr. Rashmi, and the same very small doses are also being used, given as infusion form. In our institute also, there have been few of the studies conducted with these very small, very little and little more kind, very different doses in the small dose range, and those have been shown to be effective. To the point, people have not been using it or omitting it at all, continuously giving as a loading dose. They are only using an infusion in the bottle, not giving as a loading dose fast. So that is also effective. I think that is a good strategy to use very small dose or over infusion to avoid its, hypotensive side effects, which can happen in patients.
I would like to add, ma'am, we had the one case of this peripartum cardiomyopathy. In that case, we also used as an infusion only. 4 units we added to 100 ml and then we gave it slowly. And the effect was quite good.
Yeah, that is perfect. Actually perfect. Okay, anyone else to add or to have some query?
I think this problem should have been discussed pre-hand with the gynecologist in the preparation of the surgery itself. That would help this dispute rather than, as Dr. Ishvir said, they keep on asking, pushing, give more, give more.
No,
Early deliberation helps.
not in a case of sir peripartum cardiomyopathy. I was talking otherwise.
Otherwise also. Okay, fine. But well said. Dr. Popley also added very nice, fact to it that a prior discussion is very, very important. Now, I think we can move on to the next topic. Dr. Sangeeta, you can take. Dr. Singhal? Dr. Singhal, are you around?
Yeah.
Now you can take up for the next please.
So Dr. Devesh is ready? Yeah, okay.
Sorry for the technical snag. Good evening once again, dear seniors, friends and colleagues. I shall be covering the talk in next 20 minutes and I'd like to take as many as questions which are possible. So can you move to the next slide? My slides are being played by Dr. Naveen Malhotra. Thank you, sir. Learning objectives we have already gone through. We'll basically try to understand the obstetric terminologies and practices. And can we move to the next slide, sir? So basically, hypertensive disorders of pregnancy have undergone certain change in the definition, and this change in the definition was there in 2013 by the task force of American College of Obstetricians and Gynecologists. The first and the foremost is chronic hypertension, which is less than 20 weeks of women is hypertensive, and she can have a superimposed preeclampsia. The other being the gestational hypertension, which is more than 20 weeks, but without proteinuria. And the topic of discussion for today is preeclampsia, which I shall be discussing in the next slide. So how do we diagnose? Previously, there was a triad of weight gain, edema, and hypertension and proteinuria. So nowadays, edema is not required and proteinuria is one of the components, but if proteinuria is absent, the patient can still have a diagnosis of preeclampsia if the blood pressure is more than 140/90 on 2 occasions with any of these features like thrombocytopenia, less than 1 lakh, renal insufficiency in the form of creatinine greater than 1.1, and impaired liver functions like SGOT, SGPT greater than twice the normal concentration, pulmonary edema, cerebral or visual symptoms. So can we move to the next slide? So preeclampsia, dear friends, it's a multi-system disorder. On one end of the spectrum is a woman who has just hypertension and proteinuria and is having an uncomplicated course. And on the other hand, we have severe preeclampsia, which can be complicated by either eclampsia, HELP syndrome, or we can have an atypical preeclampsia. So as regards pathogenesis, there are multiple theories which have been propounded. So on the background of a genetic predisposition, we have impaired trophoblastic invasion of the spiral arteries, thereby leading to poor remodeling and thereby leading to reduced placental perfusion, which leads to a host of reactions by the placenta leading to a chronic uteroplacental insufficiency and endothelial cell dysfunction, whereby there is a mismatch between the vasoconstrictors and the vasodilators, and the concentration of the vasoconstrictors increases like anything in the maternal blood. Next slide, sir. So first we'll try to cover the treatment of hypertension, which is very important to the gynecologist as well as the anesthetist. So there have been guidelines by the ACOG and published very recently, 2019. They keep on updating these guidelines. So systolic blood pressure greater than 160 and diastolic greater than 110 millimeter mercury at 2 occasions, 15 minutes apart constitutes a hypertensive emergency in the obstetric context of preeclampsia. We have to understand it's the degree of systolic hypertension which is the most important predictor of cerebral injury, and maternal hemorrhage is the cause of death in such patients. So it is the systolic hypertension which we have to manage immediately. The goal is not to normalize BP, but we have to achieve a pressure range of 140 to 150 and diastolic being 90 to 100. And we all have to remember that magnesium is not an antihypertensive drug in the context of obstetrics. So there are certain antihypertensive drugs which are available to us as the first line drugs suggested by the ACOG or the second line drugs. Labetalol, hydrolyzine, and per-oral nifedipine as the first line drugs. And in case BP is not being managed by these first line drugs, we can switch over to second line drugs being nicardipine, esmolol, and sodium nitroprusside. So how do we use labetalol in such a patient? So if we see the conventional hypertension management and management of hypertension in obstetric patients, the dose of labetalol required is much more. So we need 20 milligrams over a period of 2 minutes, and we can repeat if our target BP is not achieved in 10 minutes. Subsequent dose has to be higher. It has to be 40 milligrams, then 80, a repeat 80, and we can give a loading up till 220 milligrams. In case we are not able to maintain our thresholds, then we can switch over to the other drugs, which is IV hydralazine. Next slide, sir. So hydralazine can also be used as a first-line drug, either as a 10 milligram over a period of 2 minutes. Since it's a peripheral vasodilator, we have to wait for 20 minutes for its effect to act. Then we can give another 10 milligram. And if our thresholds are not reached of reducing the blood pressure, then we have to switch over to labetalol. So now coming on to eclampsia, which is a seizure superimposed on a woman with preeclampsia. It is pathologically related to cerebral vasospasm and particularly related to loss of cerebral autoregulation. Its incidence is quite high in our country and mortality is also high. And the number one cause being maternal hemorrhage. So patient with eclampsia will have some kind of preceding symptoms which are known as pre-monitoring symptoms, which are present in 80% of the patients in form of headaches or visual disturbances. Only 20% of the patients will report no neurological symptoms before a seizure. So a good pre-anesthetic checkup by an anesthetist, particularly asking about headache and visual disturbances in the preoperative period, is necessary. As regards timing of seizures, according to this paper, which I have cited below, majority occur during labor, that is around 44%, and they can occur also in the postpartum period, around 26.3%. So there are enough trials to prove that magnesium is the drug of choice for the prophylaxis as well as the treatment of seizures. The loading dose which has to be given is around 4 to 6 grams with the infusion rate around 15 to 20 per minute, followed by an infusion via pump at the rate of 1 to 2 grams per hour. In case a patient throws a seizure on a patient being on infusion, we can repeat a 2 gram loading dose again. So this drug has got a narrow therapeutic margin, and the best it is monitored by a clinical signs and symptoms like respiratory rate, it has to be more than 12, urine output more than 30 ml per hour, and the presence or absence of patellar tendon reflex. The patellar tendon reflex is the first to be lost. It is lost at a therapeutic around at 9 milligram per deciliter. So whenever the patellar tendon reflex is lost, it means patient is going into toxic range. The best is to stop for 2 hours, send serum labs, and then to review again the magnesium regime. Next slide, sir, please. So who should be treated with magnesium? So according to the current guidelines, patients with severe preeclampsia or eclampsia should be treated, whereas some guidelines from WHO or CMQCC say patients with mild features can also be considered to be treated with magnesium. If patient is not controlled on magnesium for seizures, the second line drugs are to be used, for example, midazolam and phenytoin, which are very familiar to the anesthetists. So what are the, as anesthetists, what laboratory tests are we supposed to order? It includes CBC, which will give us a platelet count, which the importance of which we are going to discuss in subsequent slides, the coagulation profile, the KFTs, and the liver function tests. Next slide. So as the role of echo was being discussed in peripartum cardiomyopathy and various views were there, then the question which comes in preeclampsia is echo required? If facilities are available, my answer would be it should be done, because preeclampsia and peripartum cardiomyopathy can be associated in 5 to 10% of the patients. So how do we distinguish? Preeclampsia would generally present with a diastolic dysfunction, whereas peripartum cardiomyopathy, as discussed by Dr. Rashmi, would be a systolic dysfunction. Patients who are very sick in preeclampsia can also have stress-induced cardiomyopathy, and they can have systolic dysfunction. And there we need the help of cardiologists to distinguish between the two. The preeclampsia can have some kind of pericardial effusions. Next slide. So pulmonary edema is another cause, second cause for death in such patients. And we all know the reasons. It's all related to the endothelial dysfunction, decrease in the oncotic pressure because of proteinuria. The mortality is around 3%, and 70% of the episodes of pulmonary edema happen in the postpartum period. And as I discussed the fluid management, restrictive fluid policy is helpful in managing a pulmonary edema case. HELP syndrome, we as anesthetists must know, it's an acronym for, it's a crowded slide, sorry. It is an acronym for hemolysis, elevated liver enzymes, and low platelet count. One must remember that if the patient has been diagnosed with HELP, the platelet counts drop very rapidly at approximately 40% per day. The lowest count is observed in the post-operative period when we have already given regional anesthesia. So I'll discuss the anesthetic considerations of low platelet count. Next slide. So what is the choice of anesthesia? We have options between general anesthesia versus regional, and spinal anesthesia is the clear winner. So I'll discuss how spinal anesthesia is a clear winner. So let's go into some kind of a historical perspective. As early as 1949, in American Journal, there have been reports of 24 cases where they have successfully managed the anesthesia part in preeclampsia and eclampsia, the severe one, with the successful usage of continuous spinal anesthesia without any adverse effects on the baby or the mother. And this were again published in 1952. Because of all these reasons, in spite of good evidence being available, our anesthetists were a little reluctant to practice the spinal anesthesia for such patients till 1990. The main obstacles in their mind, hurdles in their mind, was that neuraxial anesthesia will cause precipitous hypotension in the background setting of a hypertension. Hypotension, if it occurs, it will lead to fetal harm, and overzealous treatment with fluids and vasopressors can precipitate pulmonary edema. These three factors were there in the mind of anesthetists till 1990, and they were generally using general anesthesia or epidural anesthesia for managing such patients. But from mid-90s, there was randomized controlled trials which were published, which demonstrated the safety of spinal as well as CSE anesthesia in this population. And this is how spinal anesthesia gained acceptance as alternative to epidural and general for such patients. So this is an excellent review article as regards spinal anesthesia and severe preeclampsia, published in Anesthesia Analgesia in 2013, where they have analyzed the various studies which have been published, and they have clearly given their verdict as spinal anesthesia is the preferred technique for such patients. Compared to a normal pregnancy, it causes less hypotension, and hypotension, even if it occurs in such patients, is easily treatable and doesn't lead to adverse outcomes. So a question which comes to mind of anesthetists is, why is it that there is less hypotension in preeclamptic or eclamptic patients? This is all related to the mismatch between the vasoconstrictors and the vasodilators. The vasoconstrictors are increased much more than the vasodilators. That is why the women who have preeclampsia experience less hypotension, and they require less vasopressor support in case hypotension occurs. So I'll take you through certain guidelines. These are international consensus statements on the management of hypotension with vasopressors and fluids during cesarean section, where they have highlighted under one heading, the management during preeclampsia. These guidelines were published in 2018 in the Anesthesia Journal. According to these guidelines, the alpha agonist drugs like phenylephrine, norepinephrine are the most appropriate agents to treat or prevent hypotension following spinal anesthesia. The aim should be to maintain systolic arterial pressure greater than 90% of an accurate baseline, and never allowed to go below the 80% of the baseline. So in our country, majority of the centers are still using mefentremine. So what is the status of mefentremine in the management of hypotension? Excellent review article, the network meta-analysis published in British Journal of Anesthesia this year, 2020. It clearly states that norepinephrine, metariminol, in the results section you can read, the norepinephrine, metariminol, and mefentremine had the lowest probability of adversely affecting the fetal acid-base status. The rank order is like norepinephrine, mefentremine, metariminol, phenylephrine, ephedrine being the worst. So this is good news for us because majority of us are still using mefentremine. So mefentremine can still be used in such patients. So as regards fluid management, how much fluid do we need to give in preeclamptics? This has to be discussed in the clinical context. But what is important is that we need to have a strict input-output monitoring. A restrictive strategy is beneficial, that is around 80 mL per hour is beneficial. And in case if you have planned the spinal anesthesia, the crystalloid co-load should not be more than 300 mL. A recent RCT published in 2020 has very clearly shown the benefit of restrictive, where they had given 300 mLs during cesarean section versus a liberal where they had given 1500. There was no difference as regards post-operative acute kidney injury. So what is the lowest platelet count which is acceptable for neuraxial anesthesia and analgesia? In a pregnant woman, we have to remember that they are generally young, the epidural space is more compliant, and they are in a hypercoagulable state. That is why they have less incidence of epidural hematoma as compared to the rest of the population. So this is an excellent review article published in Anesthesia 2017, where they have studied the data available from previous journals as well as from the multi-center perioperative outcome group. They divided the platelet range in 3 groups: 0 to 50,000, 50 to 70,000, and 70 to 1 lakh. And they stated that if the platelet count is between 70 to 1 lakh and there is no HELLP syndrome, then the chances of the mother developing a epidural hematoma is around 0.2%. If you have less than 70, then the incidence between 50 to 70 is around 3%, and between 0 to 50 is 11%. So the take-home message is that above 50,000 and it is not rapidly falling and the patient has not got HELLP syndrome, we can consider neuraxial anesthesia as our first anesthesia of the choice. And the coagulation profile has to be available to the anesthetist within the last 6 hours. That is what these guys have suggested. So majority of the times we have to give regional anesthesia, but sometimes we might require general anesthesia. So what are those conditions where we need general anesthesia? One is the altered sensorium, where patient cooperation cannot be sought for, which is the #1 requirement for giving a neuraxial anesthesia. Second is a coagulopathy or a thrombocytopenia less than 70,000, or the patient has developed HELLP syndrome and there is a rapidly falling platelet count, where we would not like to attempt a neuraxial anesthesia. A severe hemorrhage, a systolic heart failure, or valvular stenosis. In such situations, we have to consider general anesthesia. Next slide. So whenever we consider general anesthesia, we have to anticipate a difficult airway in such patients, because the upper airway edema is much more exaggerated as compared to a normal pregnancy. And we should anticipate an exaggerated intubation cardiovascular response, and it will lead to rise in systolic blood pressure and a CVA, which is a #1 cause of death. And second, it can lead to pulmonary edema, which is a second major cause of death in such patients. Preferably have 2 anesthetists, have a difficult airway card with video laryngoscope, small ET tubes, and definitely have an algorithm from Difficult Airway Society pertaining to obstetrics with you before actually you give general anesthesia. And keeping in mind that magnesium, if the patient has received, would lead to prolongation of neuromuscular blocking agents. So how do we prevent the hypertensive response at the time of laryngoscopy and intubation? It's an excellent review published in Anesthesia Analgesia 2014, where the authors have stated that you use either esmolol or NTG along with propofol. The dose of esmolol is higher as compared to normal patients. It's around 1.5 milligram per kg body weight, or one can use a loading dose of NTG as 2 microgram per kg along with propofol of 2 milligram per kg to blunt the hypertensive response in such patients. So take home message, my dear friends, it's a multi-system disorder. It's a spectrum. It's not a single disease. It's a spectrum. As anesthetists, we are called in the ICUs, in the operating room for control of blood pressure and the seizures. And spinal anesthesia is the anesthesia of choice. Preferably platelet count more than 1 lakh. Between 70 and 1 lakh, one can consider spinal anesthesia. It leads to less hypotension as compared to a normal parturient. Crystalloid co-load around 300 ml, and a restricted fluid approach is what is going to benefit the patient. Thank you very much for the patient listening. I'm sorry for the technical snag once again. Any questions, I'm more than happy to answer.
Yeah, very nicely deliberated, Dr. Devesh. You covered your topic nicely. I also agree with you, because of late, the regional technique have been very popular, and they have documented benefit in cases of PAH. And definitely keeping a MAP target of 90 or more than that, or a regulated fall, helps the patient. And it gives you a good outcome. So, any question from the our audience? Anything to add? Dr. Sangeeta is also there.
Yes, thank you, Devesh. I think it was a very well researched and I think an excellent presentation.
Thank you.
And I just want to know, is there anything about role of any blocks, like, you're doing ultrasound and using a lot of it. So role of any of the blocks, which you would like to share, which could, be helpful in this group of patients?
Yeah, ma'am, certainly TAP block has been researched a lot, and there are systematic reviews and meta-analysis that TAP is effective in managing post-operative analgesia for such patients. But in Western countries, what they have done is they are giving morphine intrathecally. So intrathecal morphine of around dose of 100 to 200 microgram is more effective than a TAP block. But in our country, I don't think many centers are using intrathecal morphine. So majority of us can go for a TAP block or a ileoinguinal ileoepigastric block after the surgery is finished. And it gives good analgesia for around 18 hours if we add dexamethasone to the drug.
I think you have very well highlighted, the dose of labetalol, which we generally use, and what we need in this group of patients. I think we really don't go so far, we just use the initial 20 and 80 and then think that, okay, let us switch to the second line. But I think that is something which we all can keep in mind that, high doses of labetalol may actually be required in
Because
these patients.
as anesthetists, we generally manage hypertension with hardly 5 to 20 milligrams of
Yeah,
labetalol.
that's what.
But
So
such patients have got very high circulating level of vasoconstrictors. So they require a high dosages and you need to be very aggressive. Like every 10 to 20 minutes, you need to repeat. Generally, we keep on waiting, and that is the time when the blood pressure crosses more than 170, 180, and it can lead to cerebral vascular accident.
So, any other questions from anybody else? Anything somebody would like to add?
And Dr. Devesh, what is the cutoff of heart rate for labetalol when you use it?
See, you can, for bradycardia and asthma, it is stated, and AV blocks, labetalol should not be used. But generally, such patients will be having a higher heart rate. So as it starts dropping, if it's reaching around 60, 65, then you can hold on to the next dose of the labetalol and think of hydralazine.
Good evening, sir. I have a question, sir.
Yeah, please
Sir,
show.
patient who have eclampsia, after how much time can we give for a regional? A patient has thrown fever, and after how much time we can effectively give a regional anesthesia?
So the urgent aim would be to stabilize the mother once she has thrown a seizure. Either she can be given a loading dose of Maxelf if she has not been on that. If she has been on that with the infusion dose, you can repeat the dose to control the seizure first. First aim is to control the seizure and stabilize the mother. And as urgently as possible, if we can take the patient to the theater, that's what our obstetricians would want, we can go ahead. But please remember that in case of a stable patient, the coagulation profile available within the last 6 hours would do. In case the patient is unstable, it's better to have a coagulation profile with platelet count within last 2 hours. That is the minimum time. Till the time coagulation is available, that time you have to wait. It will take around 30 to 45 minutes for the coagulation to come. That's what I have seen in my hospital. In case you are having a point of care testing where PT, ABDT and platelet count is available, you can take as urgently as possible. Provided the patient doesn't have the neurological status is favorable. It should not be that patient is in drowsy and is uncooperative for regional. That is a big contraindication.
Okay, thank you, sir.
Hello. Hello.
Devesh, what's your experience regarding labor analgesia in patients with PIH?
So, sir, labor analgesia, as per theoretical guidelines, should be offered earlier than the conventional patients because of the falling platelet count. So, whenever a patient requests and the gynecologist says it's a favorable profile for a normal delivery, then I think we should go for a labor analgesia. But generally what happens is we generally get such patients in a state where they are not favorable for vaginal delivery, they would likely to be going ahead with cesarean because of some complications. And they are generally referred from nursing homes where already some complications have already happened. So I don't have much experience, limited experience in such patients. A well-treated, well-controlled, yes, we have given, but once the complications like seizures are set in, it goes into the category of a severe preeclampsia, severe eclampsia, and then definitely cesarean delivery has to be done.
Right.
I just want to ask Dr. Devesh. Hello?
Yes, sir. Yes, sir, please go ahead.
In institutions, this all the protocols and the necessities and the equipments and this help at hand, all these things can be managed. So what is the take-home message for the practitioner forum who are just getting an off call? There is a PIH case and we have to do a cesarean. So those people even not knowing the patient in what condition, and when they go there, they have no option but to just to go ahead with anesthesia, and they might end up in troubles. So
I think
here, can we just give a message for those people?
My take would be in peripheral setups, we can do preeclampsia without severe features. I'll again stress upon without severe features, they can be operated in the peripheral setup. Once the severe features set in, which is elevation of the liver enzymes or headaches, vomiting, right epigastric pain, or elevation of creatinine, it's better to shift such a patient to a higher center. So preeclampsia with severe features or established eclampsia definitely you cannot do in a peripheral setup. So preeclampsia without severe features, please go ahead. And preeclampsia with severe features, transfer to a higher center.
Dr. Devesh?
Yes, ma'am.
I wanted to ask you something about short-acting beta blockers, the role of, can you just enumerate few sentences upon like atenolol or intraoperatively especially, or like atenolol or esmolol in the role for PIH, preeclampsia?
Ma'am, to best of my knowledge.
Am I audible to you?
Yes, ma'am. I have heard your question. I'll answer, ma'am. To best of my knowledge, atenolol intravenous, I think, is not available in our country. Maybe Western countries if it's available. As regards
esmolol,
a lot of research has been done by ACOG, and they have come to the conclusion that labetalol is the drug of choice. The reason being its effects are persistent, whereas esmolol is a very short-acting drug. Its half-life is around 9.2 minutes. So at the best, it can be used to blunt the hypertensive response to direct laryngoscopy and intubation at the time of giving general anesthesia. So, and it is a second-line drug as per by the American College, and they have done a lot of research on this. So we should stick to first-line drugs. Labetalol, hydralazine, both are available in our country, and majority of the cases we should be able to manage. In very resistant cases, we require some other drug. Majority of the cases we are able to manage with these two drugs.
Infusion of esmolol can be used in resistant cases.
Yes, it can be used. It's a second line drug, ma'am.
Second line drug.
I think, Dr. Naveen, most of the things have been covered. So we can call it a good session. Both the topics were
very well elaborated.
Very nice presentation, Dr. Devesh.
Thank you, sir. Thank you very much.
Initially, Devesh had some issues with the screen sharing.
Sorry for the technical glitch. I'm feeling embarrassed about that this time.
No, I think you had an excellent assistant with you.
Sir, I give you full credit. I was feeling proud that I'm the opening batsman for this academic webinar, but Dr. Rashmi took over the. It's okay.
I think never mind that. It's a part of the game, we should say.
Yes.
And both the talks were very nice, excellent. Devesh and Rashmi both have deliberated very nicely and covered the entire topic very well. Thank you.
Ma'am, it should have been Lily first. That is why the things went wrong with me. Had Dr. Rashmi been the opening batsman, things would have progressed very smoothly. Thank you, ma'am. Thank you.
And we are very proud of the javels we had today.
If there are no other questions, I think we can wrap up. And before that, I must say thanks to the chairpersons my seniors and respected Dr. Savita Saini, Dr. Singh, who have continuously guided us, Dr. Sangeeta Khanna, who is at the Premium Institute and she is always there to help. Dr. Suvidha Sood, she is there to help us at the back each and every time whenever we call her. And the speakers for the excellent talk. I'm really grateful to them that at a very short notice, they were able to prepare this. And not last but not the least, the ISA National Secretary, Dr. Naveen Malhotra, he has always been the brain behind all such activities. Dr. Sunil Sethi, he supported us with all the help. Dr. Yashveer Arya, he is also there for the support. And the audience. Without the audience, this would have not been successful. So thanks a lot to everyone. Let's wrap this up.
So we meet next week, Dr. Nirupma.
Sure.
Yes.
So I think I'll request next week host is organized by ISA Rohtak City branch. So I'll request Madam to make the formal announcement for that.
Yeah. Thank you, Dr. Naveen. And Dr. Sethi had told me that it is they are starting with Faridabad, and next is the turn for Rohtak. So next week we'll be meeting, and the topic has been, rather the theme has been finalized that the top topics would be on neuroanesthesia. So the two topics which would be shortly finalized and will be then informed to all of you. So we'll be taking up these two for two talks on neuroanesthesia. So this is for all of us to be there, and good number should be there for participation of all other participants as well.
Thank you, ma'am.
Would again be announced later.
By in a day or two, because it's next Sunday. And Dr. Sangeeta Khanna, we are meeting next Gurgaon. So we shall be doing it on 18th or 20th. Dr. Sethi had given me some input.
Edwards meeting.
You've been able to speak to them?
Yes.
Okay. So then I think we'll finalize it and we'll let you know then.
I will call him tomorrow morning and
okay.
We'll preferably like to do it on Sunday, 20th.
Yes, that's fine.
But if they want to do it on 18th, then we will Gurgaon. We can do it on 25th. 27th.
Okay.
Right. So
right. That's fine.
That can be finalized.
Okay. People who have given their email IDs, they will get the e-certificates. Right, Dr. Naveen?
At least we can note down the...
They are writing in the chat box. Faculty and the organizing committee will automatically get it. The delegates will get those who written their email ID, or they can WhatsApp it to Dr. Sethi or Dr. Yashveer Arya, and then it will be done. So final concluding remarks by the presiding officer of today's function, Dr. Sethi.
It was a great pleasure for me to start this activity in Haryana, and we know this corona pandemic will continue for further some time. So with continuing efforts of the faculty from all over Haryana and guidance from the ISA National, we are proceeding with the series of webinars, and we will like to cover all the topics which are very, like I was talking to Dr. Devesh also today, that the things have changed. Those who are in practice, those who are in medical college for long back, the things have changed. So we need to brush up the things, and with the able guidance of the national leaders and my seniors, my teachers, and my junior colleagues, we will improve our vision for the anesthesia in the periphery as well as in the institutions. And as Dr. Savita Saini has consented that next time we will have in Rohtak, then we will have in Gurgaon. So look forward for the activity. And thank you very much, Dr. Naveen, for the continuous support. And in future also, we will have your guidance. Thank you very much. With these remarks, I thank all the chairpersons and the esteemed speakers, Dr. Devesh and Dr. Rashmi. Thank you very much, ma'am.
I congratulate personally Dr. Sunil Sethi for organizing all these events and academic activities all over the state. And it is actually a very good, say, creative action for the entire society of our anesthesiologists. Thank you.
Thank you.
Thank you.
Thank you.
Okay.